Here.
Andrea, your hair looks pretty.
All right, we got the recording going. I see that. All right, so let's call to order. Today is December 5th, Tuesday. Time is 9 o'clock. The meeting is the SEOW work group under OEB. And roll call is Tom and Bill are here. And from PEB, we have Andrea and Greg are present. Absent, excused are Rob and Sue. Is that good enough for roll call? Rose, you got it? All right, so we're going to pass on voting for the minutes for last month's meeting. We'll do that doubled up in January. We'll do the November and December minutes in January, and just move right into the topics. So today what we're going to do is discuss the weight loss drug coverage options, and followed by the doula coverage options that were done in the committees that were set up, or the work groups that were set up to investigate these things. I want to point out for those listening, what we're going to do today for GLP-1 weight loss drugs discussion is open the discussion, and it's today, and hopefully in the afternoon meeting with OEB, we will be just introducing all the facts and materials to all the members, and we'll go into a little more detail here in SEOW. But the point of today is to just really get into the delving, to get everybody's minds associated with this topic and the details of this topic, so that they can think about it for a while, and then we'll bring in the decision, the recommendations and everything that we're going to do to direct the carriers will be in January. So this is really to bring out the things that we have, understand the data that's being presented, and to think about what other data needs to be achieved to make a recommendation in January. Questions on that overview of what we're talking about? And it's kind of sad, actually, that Sue and Robert can't make this discussion, but we will work them into the program as well, individually. Tom, any comments?
My only comment is really to encourage comments from Greg and Andrea to help us with this. That's the only thing. And I'm hearing someone isn't muted. I'm hearing some background conversation. So if people can check
muted
and make sure
Tom.
that. Okay, good, thanks. Rose, you're
I can mute
you're
people.
Our protector. Thank you. Wonderful.
Absolutely.
Just don't do me.
So we're going to start off with weight loss, the GLP-1 discussion. And again, we're all coming at this from different levels and different perspectives. So let's ask lots and lots of questions and make sure we understand all the concepts that are being presented here. Kirsten, is this you starting off the discussion?
Yeah, I'm going to interrupt real quick. Rose, this is where we're going to take over with screen sharing.
Thanks, Maya.
Yeah. Okay. I was just going to let you kick me off, but I'll leave.
Okay.
And Bill, we're going to have Sarah Drake, our clinical pharmacist, kick us off, and we'll hear from Dr. Ian Chuang, and then I'll take over later in the presentation when we start getting to some of the financials, but we'll let Sarah Drake take it from the top.
All right.
Okay, thank you.
So that's what I look like on your screen. All right. Yeah, I can.
Okay, excellent. So let's go to the next slide. We've got the agenda. Yep. So we're going to talk about background, and we're going to talk about some considerations. Let's go to the next slide. And so as is mentioned earlier, what we're hoping to do here is identify the additional information that's needed by the SEOW committee to help move forward and develop that recommendation. that ultimately that recommendation would be forwarded on to the OWEB and the PEB boards. So before we get started today, I think I want to acknowledge this is a really important and it's a really complicated topic. We want a robust discussion, and that might mean that we don't get through everything here in our allotted time today, and that's okay. We can pick up the discussion in January and continue on. We don't want the group to feel rushed, and we want the discussion to be meaningful for all. Second of all, I want to recognize and acknowledge many of the themes that are coming in from the public comments. I think we all know obesity and cardiometabolic disease, it's challenging, it's a chronic disease. There are many people in the US, including many people who are enrolled in the PEB and the OWEB plans, have spent months, years, maybe decades trying to treat it with various regimens of diet, exercise, maybe even prescription drugs or supplements that are marketed for weight loss, and they still haven't made progress in treating their disease. So these drugs do represent a new tool in the toolbox that people haven't yet had the opportunity to try due to a combination of availability and also cost factors. And they are understandably eager to try them. And you can feel that in their comments. So as we go through the conversation today, that's going to include a lot of detail related to the complexity of both how the drugs work and how our US healthcare and drug pricing system works. I don't want us to lose sight of the member experience and the sense of urgency that many of the members might be experiencing and feeling right now. Also, want to call out that the use of BMI, and you'll see it in our deck too, body mass index, it's used at the population level to measure overall risk of the population, but it's not universally useful on its own as a measure of cardiometabolic health. It can be an indicator that obesity or disease is more likely to be present, but it doesn't on its own indicate the presence of disease. There are individuals who have larger body types that are healthy. There are people with low BMIs who have cardiometabolic disease. So our goal here is definitely not to medicalize larger body types, just as our goal here is not to give members a tool that allows them to achieve a certain look or fit into a certain size of clothing. Our goal is to evaluate the use of these drugs as part of an overall regimen to help people achieve cardiometabolic health. And so, in other words, the discussion of coverage needs to acknowledge that successful treatment of this complex and chronic disease generally, it can't be accomplished through drugs alone. We need to acknowledge the environmental, the social, the lifestyle factors that have continued and they have contributed to the rise of cardiometabolic disease in our workplaces, in our society. And we need to think about how do we move upstream? We've talked in the past, how do we shift left? Help people be successful in maintaining a healthy cardiometabolic state over time? And how do we prevent more people from developing obesity and cardiometabolic disease? So before we get started, I see a hand up. Tom, did you have some comments too?
Sorry, I was on mute. Yes, I do. The issue, I agree with you 100% that BMI is a populational number. My question, and one that needs to be addressed, is whether or not, for sure that's true of a BMI of 30. Is it also true for a BMI of 35? And what about a BMI of 40? In other words, if you're at a BMI of 40, what percentage of people are in a healthy state? So it's, like if it's a BMI of 30.01, my guess is that there's maybe 30% of the people who are also, quote, healthy. I'm making those numbers up. If your BMI is 40, then you may be at, so what we're dancing around here will be the ability, whether or not we have an ability to craft something that identifies the use of these medications for the people who are at most risk. And the question is how to do that. And we may need to work on that issue. And I'm just gonna, when I have ideas, this is parking lot. I'm not saying we have to debate each one. You had mentioned that we had a lot of comment from the public comment. And the one that got me, another one I want up on the parking lot, and that actually may need to be started addressing very soon, was ones from the legislators where they talked about they're recommending that we get rid of the exclusionary language around use of GLP-1s and saying that does not actually force our hands. My worry is that it actually does, that without the exclusionary language, you would be hard pressed to deny that as a treatment. The way that if in the past not covered things for whatever reason has been because we have exclusionary we have exclusionary language in our contracts. And eliminating it, my guess is that the barn doors open and the horses are charging out. Again, regardless of whether or not it's the right thing to do. So this is one that I think we need to get on really quick, and may even require Department of Justice opinion, and maybe Mercer has experience with this in terms of looking at their contracts. When you come up with something where you actually, like one of the recommendations, obviously running down at the end of the comment is maybe we postpone a year. For us to be able to do that, my guess is that we need to have exclusionary language. So those are my two takes. Sorry for jumping in and ruining the rhythm, but you opened the door for us to be able to comment willy-nilly.
Yes, that's what we want. So thank you, Tom. Ian's got his hand up too, so I want to give him a chance.
Thank you. And I want to just add on to Tom's first comments, and I think it will be important as we discuss today through today to put in context, right? There's two kind of aspects to this. One is how I would describe it is the coverage decision, which in my mind is about defining appropriateness to consider treatment, which will be based on clinical criteria, right? So this is just creating that coverage parameter. That's versus the necessity to treat, which to Tom's point, for an individual of a certain BMI as the initial criteria, there is an element of clinical judgment. There is a necessity to treat using GLP versus an alternative medication, and this ends up being a joint clinical decision making between the prescriber and the patient. So at the end of the day, that's ultimately the physician's responsibility. So to assess the otherwise healthy obese individual, there's a set of complex criteria for that, and that's obviously a clinical treatment option. So that's important to clarify that right now we're talking at a coverage level. Hope that helps.
All right, thanks. We can go to the next slide. We're going to start in with some background on what GLP-1 drugs are. So next slide. So this is it's a brief overview of what a GLP-1 drug is. GLP-1 stands for glucagon-like peptide 1, which is no fun to say, and that's why we abbreviate it. It's a hormone, and it's produced in the intestine in response to the presence of food. And so the GLP-1 drugs, they're referred to as GLP agonists, which means they're able to artificially stimulate the same receptors in the body that the GLP-1 hormone that's naturally occurring is able to do. That GLP-1 hormone increases the production of insulin. It encourages the release of insulin from the pancreas, and it increases the feeling of fullness during and between meals, both by slowing down the emptying of the stomach and also acting on the appetite centers in the brain. This class of GLP-1 drugs isn't new. They've been available, the older versions have been available for the treatment of type 2 diabetes for over 15 years now. Some of the first products available had to be given once a day as an injection. The newer products we're seeing now are a once a week injection. We're even seeing some oral product. We have one oral product on the market for treatment of type 2 diabetes. FDA approved Wegovy, for use in weight loss or treatment of obesity in conjunction with diet and exercise back in 2021. And Zepbound was approved just last month. So today, OEB, PEB, Medicare, and Oregon Medicaid exclude coverage of weight loss drug treatments, not exclusive to GLP-1s, but it does include that the GLP-1s are excluded. As I alluded to earlier, we're going to explore opening up coverage of these products, and there are complex considerations, and we're going to go over several of those today. The drugs have the potential to be part of a regimen that's helping people move towards health, but we also need to think about safety considerations as well as social, environmental, and cost factors that need to be explored too. So with that, we can go to the next slide and talk a little bit about how did we get here and how did this end up as part of a summer research group. Last renewal, we focused a lot on shifting left, including the cardiometabolic treatment spectrum. And as part of that spectrum, we had to recognize the development and increased utilization of the GLP-1 drugs in this area, right? By bringing it to the summer work group, we had the opportunity to study and include also participation from both OEB and PEB. The group met several times over the summer, and we also had participation from the carriers, state staff, Mercer, and both of the boards. The goal of the summer work group was to examine options for GLP-1 coverage policy for the treatment of obesity, and then share options back with SEOW for public deliberation. So here we are. And I think it's important to call out that the GLP-1 drugs are currently covered in both OEB and PEB for treatment of type 2 diabetes. So the focus of the research group was exclusively around potential for coverage of these products for the treatment of obesity. We go to the next slide. This one just has a little bit more detail on who all participated in the research group and what was considered throughout the process. Broadly, we looked at putting together coverage policy options, which are going to be discussed today. We also considered how and when the GLP-1 drugs fit into the overall treatment spectrum for cardiometabolic disease. We looked into the FDA label requirements and off-label options, and we're going to get into a little bit more detail in what an FDA label is and what that means in a few slides. We talked about utilization management, such as prior authorization step therapy, looked at lifestyle programs that could be used alongside GLP-1 drugs, looked at the clinical effectiveness relative to other treatments for obesity and overweight, and also looked at overall cost in comparison to those other treatment options. I want to call out that the group was focused on coverage and treatment for adults, and we did not delve into coverage for children or adolescents at this time. And the group also didn't weigh in on any specific lifestyle modification program that would be optimal. Yeah, Tom's got his hand up.
A quick question about just how this, the research group, whether or not there was consensus during the conversation and development of recommendations. I mean, three different people coming at the problem from different directions, and I just wanted to get a sense of how things worked.
Yeah, I would say that there was definitely a lot of healthy discussion and deliberation. We discussed considerations from a lot of different perspectives. I wouldn't say ultimately that it came to consensus, but we came to a couple of options that we wanted to present and talk about today. I think I saw a thumbs up there. All right, let's keep going. Next slide. So this slide is an overview of the current coverage landscape. While it is definitely true, and I think we saw that in some of the public comments, that some payers, including some payers in Oregon, are currently covering the GLP-1 drugs for weight loss, the majority of Americans actually do not currently have coverage. Only about 35% of private employers are currently covering the GLP-1 drugs for weight loss. And that limitation has been largely due to concern about growth of utilization, growth of overall cost. We are hearing about a few public employers that are adding coverage. So for example, Connecticut, Idaho, and Florida are adding coverage, but it's going to be available exclusively through the state's selective lifestyle management vendor. Delaware and Idaho, they're also adding coverage. Definitely keep in mind, those are relatively small states in terms of population. Interestingly, North Carolina and Iowa had previously covered the GLP-1 drugs for weight loss, but they've actually had to make the difficult decision to pare that back and discontinue coverage due to higher than anticipated utilization and cost, and it just couldn't be supported by the state budget. As far as individual and small group plans, like something purchased on the exchange, they generally do not cover weight loss drugs. Medicare is prohibited from covering due to a 2003 statute that's on the books. There's drug manufacturers and advocacy groups are pretty actively, very actively lobbying Congress for a change there. State Medicaid programs have the option to cover or exclude weight loss drugs. At this point, I think there's close to a dozen states that are now covering the products for Medicaid enrollees. Oregon does not currently, but is considering coverage for individuals over 21. They're working closely with the DERP group out of OHSU to evaluate the clinical and the cost considerations of adding that coverage to Medicaid. Any questions here before we keep going? Okay. Next slide. This one probably doesn't need a lot of explanation. I've been working in pharmacies for over 20 years, and I have never seen this level of consumer interest and excitement and just conversation about drugs generally. Like, I'm popular again for the first time since like the late 90s when we were talking about Viagra. It is, I've never seen anything like it. The Kaiser Family Foundation, which I need to disclose, is not affiliated with the Kaiser Health Plan. It conducted a survey in July of this year on the public's views on the new weight loss drugs. They did a representative sample. It was about 1,400 US adults, both English and Spanish speaking. They found that 68% of people who wanted to lose 20 or more pounds would be interested in taking a drug for weight loss if it were proven safe and effective. 50% of people were interested if they were trying to lose up to 20 pounds. And maybe most interestingly, 23% of people who aren't even trying to lose weight were interested in taking the drugs. Both PEB and OEB have received a number of requests for coverage, and you can read a sampling of those in the public comments. So what's driving this demand? I think it's a number of factors, right? There's a high and growing prevalence of obesity and cardiometabolic disease in the US for a lot of complicated reasons. Many people who are seeking to lose weight feel that the standard advice of eat less, exercise more, it just isn't working for them. And we also just can't discount the impact of social media and advertising. You can see here over 500 million was spent halfway through 2023. Ad spending for Wegovy is up 1,000%. Drug manufacturers are master marketers. They know what they're doing and they do it very well. So we can't discount the impact of advertising on this. We go to the next slide. Also need to call out that there's medical providers that are advocating for coverage. This is another tool in their toolbox. The Oregon Medical Association, in their comments, they support the coverage of GLP-1 drugs and they request removal of that exclusion language that Tom mentioned. And then the AMA also passed a resolution calling for health insurance coverage parity for what they're calling clinically validated obesity treatments. And that does include products like Wegovy and Zepbound that are FDA approved. Tom, you had some comments?
My question is whether or not the OMA has also, along with this, recommended that the state change their 3.4 limitation. So one, it could be afforded, or if not, give us a recommendations of what benefits to take away from our members so that it was affordable. Or has any organized, that's specifically for the OMA with this recommendation, has anybody in the state of Oregon addressed the issue of adding something that has potential of increasing cost double digits up against the 3.4% limit that we have? Has anybody organized addressed that yet?
I can kind of answer that question. This is Glenn Bailey. The public comments that we've received, no one has addressed the impact on the 3.4%. And, need to increase the 3.4% to add or remove the exclusionary language on GLP-1s.
Thanks, Glenn.
So it's a great comment, Tom. This is Ollie. Sorry to jump in. This is like something in a normal like legislative proposal that we get, that we address, with anything that has a physical impact. So I don't know why this would be different, but I did want to also add, I didn't get my hand up quick enough, that the Health Evidence Review Commission, the HERC, and the Oregon Health Authority, for Medicaid, their pharmacy work group is likely to start hearings in January or soon thereafter regarding coverage, and we obviously stay in really close contact with them and coordination. Thanks.
Yeah, it is just another comment. It's obviously OEB as its responsibility for coming up with a plan of treatment for its members. This is bigger than just OEB, obviously, and you add in PEB, and then you add in OHA and the Oregon Health Plan. You're talking, is it a third or a third of covered lives in the state of Oregon? Yeah. So it's something, and I could imagine one of those are just the public entities. If you had different treatment, if you had different for each one, it could create kind of madness. So that is something that's going to be kind of critical. Thank you.
Andrea, you had your hand up.
I have a quick question. Does the Oregon Health Plan cover it?
No, not currently. Not for weight loss. Yeah.
Okay, thank you.
So Tom, there is groups, OSBA, my group, is one of them that is actively discussing with legislative things on the effects of the 3.4 and what other formulary type calculations can be used to replace 3.4. Those discussions have been going on. It's not just about GLP-1, it's about the whole concept.
Great, thank you, Bill.
Great discussion. Thanks, everybody. Keep raising your hands. I like it. Let's go to the next slide. And this is where we're going to take a little detour to talk about what we mean when we refer to FDA labeling or FDA labeled indications. So when the FDA approves a drug for use, they also approve the labeling, and the labeling includes the packaging, the carton, the container the drug's in, as well as the prescribing information, which is known as the labeling for healthcare professionals, and then also the labeling for patients or caregivers that is sometimes referred to as medication guide or a patient package insert. The drugs are required to have the prescribing information and that labeling for healthcare professionals as part of their approval. So there's no drug on the market that doesn't have this labeling for healthcare professionals with it. The drug company proposes the labeling, the FDA approves it. And again, drug can't be sold until that labeling is approved. What does this labeling look like? Where do you get it? When I was working in pharmacies back in the 90s, we didn't have internet access on the terminals at the time. So if you wanted to look at the drug's prescribing label, you had to take a little square of paper off the back of the bottle and unfold it about 20 times and get out the magnifying glass and read it. Or you could subscribe to like a big thick book called the Physician's Desk Reference, and that had all of the prescribing information. These days, the FDA approved labels, they're available on the internet. Anybody can look it up. What you can see here on the right is an excerpt we pulled from the internet from the Wegovy label from the manufacturer's website. This is the indications and usage, and also the dosage and administrations section of the label. The label also includes, that you don't see here, again, these things were huge. It includes warnings and precautions, contraindications, meaning people who should not get the drug, adverse reactions, drug interactions, use in specific populations like kids or pregnant people, potential for abuse, how do you treat an overdose, and then detailed biological and chemical descriptions on how the drug works and the results of clinical studies that resulted in the drug's approval. So it's, a little light reading. If you can't get it to sleep at night, it's a good place to go. But in this indication and use section, you see it tells you what populations and for what use the drug should be prescribed for. So in this case of Wegovy, it's approved as an adjunct to reduced calorie diet and increased physical activity for chronic weight management. And specifically, it's approved for that adjunct use in adult patients that have a BMI over 30 or a BMI over 27 with other comorbid conditions. And it's also improved in adolescents, patients over 12 that have a BMI that's in the 95th percentile for their age and sex. And the label then goes on with some limitations and some details you can read there on dosage and administrations. So why is this important? A couple things. So first, that FDA label indicates the population and the conditions under which the drug was proven to be safe and effective in the clinical studies that were submitted to the FDA. So the drug is it's proven effective in these populations as an adjunct to lifestyle changes like reduced caloric intake and increased activity. That's where it's proven to work. And also, this is important to understand because as we'll talk about later, the manufacturers of the drug might point to this labeled indication as part of their price negotiation strategy. So for example, I've seen cases where some of my employer clients, they're interested in covering the drug, but only maybe for the highest risk individuals. Say maybe they want to limit it to people with a BMI of 40 or greater. The drug manufacturer will come back and say, well, unless you cover this product for everybody for whom the drug is indicated on the label, we're not going to offer any discounts in the form of rebates. So the price is the price. So the label is an informative tool for when and for whom the drug is proven to work. And then it's also important for marketing and pricing considerations. So before we go on, I want to note that once a drug is approved by the FDA for this specific use or specific population, there's no requirement for prescribers to prescribe it only in accordance with the label. So we'll often hear the term off-label prescribing, and that's when a prescriber writes a prescription for a patient who doesn't meet the criteria on the FDA label, or maybe the patient has a different disease. So for example, prescribers can and do prescribe the GLP-1 drugs that are approved on the label only for use in diabetes. They'll prescribe them for weight loss. That's the Ozempic phenomenon we've all heard about. That said, it's common for payers to limit coverage only to the FDA approved indications, and that's currently what OEB and PEB do. In many cases, that's done to control costs, but also to ensure that the drugs are only being used for the indications in the people who are most likely to benefit based on those clinical trials that were done by the manufacturers and reviewed by the FDA. So I know that was a detour, but I wanted to make sure we were all on the same page of what a label is. So any questions on that? Bill?
Yeah, I do. So coming off the label and the fact that the government is controlling how medicine or how drugs are being used, the controlled drugs that is, what are the ramifications of the label and from legal liability if you are not covering a member that has a drug that's available for an issue that they have, chronic, say, for example? What are the legal liabilities of that?
So I want to make sure I understand your question. You're asking about what's the legal liability for a plan if they're not covering something for a drug that's available on the market.
So let's say you have a cancer drug that's available. There's only one or two. You have a member who has that cancer and you're not covering that FDA approved drug.
Yeah, I am not an attorney, so I can't comment on that. So I'm not sure what that legal liability is. It's definitely common to see step therapy. It's definitely common to have certain categories of drugs excluded from coverage. Plans have to cover what's part of the essential health benefits. They need to at least mirror the benchmark plan in the state. Getting beyond that, you're getting out of my my area. I don't know if there's any lawyers on the call.
Remind me again what step therapy means.
Step therapy generally means that before maybe a newer, more costly drug is approved for coverage, the member needs to have at least a trial of an older, less expensive treatment that has also been proven to work.
Thank you.
Yep.
So this is another parking lot issue, I think, Bill. A very important one, but this is one that is going to require a little bit more research.
That's why, and again, that's the point of this thing, is to figure out things we need to know before making a recommendation.
Yeah, great point. We can bring that back to some of our Mercer team too. I think we do have some policy experts.
Yeah, this is Glenn. I just did want to let everyone know that we have a question to DOJ right now about legal liability for coverage, especially in terms of the employment discrimination in regards to coverage, because a suit was brought in Washington for not covering one of the, I guess it was, I don't remember if it was Wegovy or Ozempic, but their initial response is they kind of need more time for research on that, but they are working on that.
I think that the key point in this particular unique situation that has me spinning is the fact that we do prescribe this drug for one condition but not for another condition that is both FDA approved. So it's not like we're not using this drug in our insurance coverage. We're selectively choosing who gets this drug, which is, that raises some anyhow. Move on.
Yeah, I mean, some of the challenge I think too is that, you know, the same drug, semaglutide, which is the generic form, it's available both as the Wegovy, and you saw the label here, the label on Wegovy, it's only approved for treatment of weight loss. And then there's also Ozempic, which does contain the same active ingredient. It's in a slightly different dose formulation. Ozempic is only FDA approved for diabetes. So currently your plan covers Ozempic, does not cover Wegovy.
Yeah, I understand, but we all know that's the same thing. Just the two labels and two names because of the different dosages, right? So,
it's because the different dosages, yep, and how it's being marketed.
So we that's the gray area, right? So yeah. Anyhow.
Yeah, no, good sidebar. Let's go to the next slide. This one's kind of relevant too, and similar to what you're talking about here. So yeah, Wegovy, it's not the only GLP-1 drug out there. It's not even the only GLP-1 drug out there for weight loss, but it's the most talked about right now. And Wegovy does contain the same active ingredient as Ozempic, which is FDA approved. On Ozempic's FDA label, it's approved for, there's glycemic control or type 2 diabetes in conjunction with diet and exercise. And then it also has an indication for reduction in cardiovascular risk in patients that have type 2 diabetes. So it's got two different indications. We might see a new indication for Wegovy coming too, where it's a reduction in cardiovascular risk for people who have higher BMI. So that's something that we're likely to see, I think, in the next 6 months. Here you can see some of the other drugs that have that FDA approved indication for weight loss or treatment of obesity. There's Zepbound. That's the one that's got the same active ingredient as Mounjaro. And interestingly, Zepbound actually comes in the same strengths as Mounjaro. So in this case, it literally is the same drug in a different package with a different label. There's Contrave. That's a combination of bupropion, which is an older antidepressant, and then also naloxone, which blocks opioid receptors. It's believed to act on the brain to reduce food cravings. There's Qsymia. That's a combination of phentermine, which is half of the old fen-phen regimen, if anyone remembers that from the 90s. And then topiramate, which is an anti-seizure drug that reduces appetite. There's also generic formulations of phentermine out there. These are pretty low cost, like under $20 a month. They are right now the most commonly used drug prescribed treatments for treatment of obesity. Also got to call out, this is the beginning, not the end of the GLP-1 wave. There's at least 12 more drugs in development, including some orally administered options. So those of us who work in the field are hopeful that additional competition is going to bring down prices over time, but also acknowledge that isn't likely to happen quickly. But we do hope that's where it goes. I also want to acknowledge out here, there's some other products on the market that are not FDA approved. A lot of us probably remember Metabolife. There's other supplements out there. They're purporting to stimulate weight loss. They have not been proven safe and effective. There's also this growing industry of compounding pharmacies that are making custom versions of GLP-1 drugs and selling them on the internet for lower prices. These pharmacies are they're operating in a quasi-legal space, and they're under limited regulation. There's been multiple reports of contaminated counterfeit product. And for that reason, I as a pharmacist, I would never recommend the use of a compounded GLP-1 drug. But that said, I have to acknowledge people are doing it. It's even referenced, I think, in one of the public comment letters. And so it's out there. And I think just the growth of this compounded options and the marketing of it, it speaks to this sense of urgency that people are feeling and wanting to try something new, along with just the unaffordable price that the FDA approved versions are carrying. Yeah, Andrea, did you have a comment?
I have a question. Again, not sure how it is. So how many decades does it take for us to be able to have a generic of Wegovy and Ozempic? What's the timeline, or is it never going to happen?
Oh, it'll happen. I'm doing the math in my head now. So, so there's Victoza, which is one of the earlier GLP-1 drugs that had a version for weight loss. Saxenda didn't get a lot of market share. It has to be dosed twice a week rather than the once a week, and maybe it's even daily. But it doesn't work quite as well. There's a generic for that now. It's on the market. Ozempic, okay. I think we're probably looking at a decade on that one, okay, because it hasn't been out as long. Yep.
All right. Thank you.
Yeah. Good question. Yeah, it will happen. It won't happen quickly, but it will happen. Okay, so with that, I'm going to stop here. I'm going to turn it over to Dr. Twang, who's going to talk about some of the considerations when we think about coverage in this category.
Thank you, Sarah. Next slide. And the next one. So I think it's important for us to sort of look at the continuum of treatment options around weight loss, and but also think of these as sort of stacked treatment options. So if we think about the treatment options from left to right, fundamental as a foundation, it is about making sure we address and optimize our nutrition as well as optimizing our physical activity, because both are important components to just a healthier metabolic state. And if we look sort of along that vertical column, the first circle, the approach would be traditional, for lack of a better term, diet and exercise programs that vendor point solutions offer. It's a various set of capabilities, different levels of digital enablement versus face-to-face sort of coaching-based models, and or combination, right? So this is sort of a set of different approaches that are focusing primarily around diet, nutrition, as well as exercise. When we look at it, and we've sort of included some references there, if we look at sort of the average weight loss at a 1-year time frame, and then we look at the estimated cost of a treatment program in this category, it's nominal, right? Both in terms of the cost of the program as well as the impacted weight loss. And again, I want to reiterate, what Sarah mentioned initially, that this weight loss drop, it's really about getting to a clinically meaningful weight loss that alters your metabolic state and physiology, that reduces the long-term downstream risk of the complications and other factors and comorbidities. It just happens that the weight is just that target marker that is correlated with what's going on physiologically. If we move to the next circle, we get into sort of the more structured DPP, or the Diabetes Prevention Program. This is a set of well-established approach, and hence those vendors and programs that follow the DPP can be certified as being sort of aligned with the CDC program that has been demonstrated good efficacy and outcomes. But even that being said, if we look again at the average weight loss, it's between 5 to 7 on average. However, the typical cost of the programs at a member level goes up a bit. So something to keep in mind. And then we get into sort of the programs that really start to go after the weight loss reduction as a primary goal. as a primary focus. And the first circle is without any non-GLP medications support or enablement. So this is still just about behavioral change, behavioral modification, and things like that. The success as measured by weight loss is nominal. However, the cost of these programs vary tremendously, again, depending on the level of face-to-face time, clinical expertise, the level of team approach to these kinds of programs. The next one, if we move on, we can start to consider what happens when we include a GLP-1 medication. Sorry, can you go back to the previous slide? So with the GLP-1s, we're showing that it's a significant incremental jump up in terms of efficacy, as good as 15+% weight loss. And clinically meaningful weight loss, typically we earmark it as a minimum of 5%, but ideally 10%, meaning when you achieve a 10% drop in your weight, there's enough physiological change beneath that it really reduces your risk of long-term comorbidities and complications. Now that we have Zepbound, that actually goes, Zepbound is the most effective so far to date. They're demonstrating about 20% plus in terms of weight loss. Now that's important to keep in mind because as we now move down this continuum, not everybody needs 15 to 20% weight loss, right? So that's where, the appropriateness to consider treatment option versus the clinical decision between the prescriber and the patient becomes important to figure out which one of these may be optimal. And again, we've heard feedback from the public feedback that, some have tried some of the approaches on the far left, and it's been challenging, right? So we know it is hard, and for various reasons, because obesity and cardiometabolic disease is multifactorial, it may not be sufficient, even though it is necessary. So that's why as we move to the right, there's still a component of nutrition and physical activity that has to anchor any efforts around weight loss and management. The last one is bariatric surgery, which is the most effective to date. It's consistently been able to achieve significant weight loss up to 20%. However, it comes at a significant higher price. However, keep in mind, this would be a one-time treatment cost because it is a procedure, whereas the cost for the column next to it around GLP medication would be a recurring annual cost, potentially, if this medication is required to be prescribed on an ongoing basis. Bariatric surgery, very effective, but it is more invasive because it is a physical anatomical change to the patient's gastrointestinal system. So with that, let me pause there.
Question from Tom.
Yes.
Yeah. So the question about the GLP-1 medication and sustained weight loss. Do we have long-term studies yet? And 5 years into maybe ideally 10 years, where we know that X percentage stabilize and are able to get off medication versus to maintain that 10 to 15%, they need continued medication, because that is such a huge component of the financial analysis.
Yeah. So we probably have more longitudinal, longer term insights from those using GLP-1 specifically for type 2 diabetes. The obesity indication followed or came more recently. So that long-term data will be evolving and will be informative over time. Absolutely. We're probably not there yet in terms of the full longest term kind of insight. However, what we're seeing with cost benefit modeling is at least about a 5-year potential impact, because those who are significant risk with obesity, significant risk meaning risk of developing cardiovascular disease like heart disease, stroke, etc. The onset can be as soon as 5 years. So the prevention of those conditions can basically be impacted within a 5-year time frame. And I think the recent study looking at Wegovy is starting to suggest that we are impacting the onset of those conditions within those time frames. But more to come, obviously, more to come on the efficacy, long-term clinical benefit, but then also the long-term potential side effects that are yet to be discovered.
And the long-term, well, just a quick follow-up. And the long-term, you know, I used Wegovy for a year and a half. I got my weight stabilized, and now I'm off it. Versus for me to keep off it, I have to continue taking the medication. So there's the long-term impact on downstream health for sure. And there's also what do you have to do to maintain that 10 to 15% weight drop.
Yeah. So the assumption for the benefit is that these weight are maintained. How it gets maintained is going to be revealed to a large extent based on how the patients align to each of these treatment options, right? So definitely staying on the medications, maintaining the weight loss is the primary track. For some individuals, if they are able to improve through other interventions, such as the intensive lifestyle intervention around nutrition and physical activity, some, and I don't have quantitative data because we have insight that it can occur, meaning some individuals can come off of GLP-1s and just through maintaining those lifestyle changes, sustain those improvements that translate to reduced long-term comorbidity. We're also seeing some anecdotes that say some individuals can be treated with GLPs and then transition to lower cost, less aggressive treatment options, medication-wise. We don't have good studies that show this comparison of those two, but definitely what we do know is those that have come off of it, because a high percentage do end up stopping the medications after a certain time period, that the weight gain does come back. So that we know for sure. That's a given. What we don't know as well quantitatively is how can we continue and sustain that? Is the continued medication the only means? The near-term answer is no, but we don't understand how that works.
Just to make sure I understand to exaggerate to make a point. If I'm on GLP-1 for 5 years and I'm losing 10% a year, I'm going to be down 40% from my current weight, which is probably going to kill me for other reasons than this is. So we wouldn't stay on GLP-1, right? Or am I not understanding the question here?
So good point of clarification, and I'll ask the pharmacy to weigh in also, but our study shows that it kind of plateaus down. So there's a threshold of maximum weight loss that's achieved. And the 15% is what has been typical for the Wegovy's, more so than Saxenda. And now with the Zepbound, primarily through the Mounjaro dosing experience, it can be 20%, but it tends to plateau. So that's where it kind of levels off.
Oh, so after the first year, the weight reduction it's not as effective in the percentages I'm looking at on this chart. Right.
Yeah,
it maintains it.
It maintains it, and so
yeah,
the concern is if
down,
they hit that plateau, and then if they stop taking the drug, it's that's what doctor's talking about. Like what we see in the data is that weight goes back up. What we're wanting to see more data on is, well, what happens if there's a lot of lifestyle change and people stop taking the drug? Can they maintain or not? And that's the part we don't really know yet.
Andrea.
Oh, just a quick clarification for the GLP-1s that are used for type 2 diabetes. I assume they take that continuously. Like that's not like they take it for 3 months and stop. Is that correct?
Correct.
Okay.
And for that, the primary indication is around optimizing the diabetes metabolism. So it's insulin resistance and glucose spikes and things like that. So we're trying to control and optimize that and using, for example, hemoglobin A1C. It just happens that it also can improve the weight, which because the two are so interconnected from a cardiometabolic spectrum, that for those individuals, it really helps them improve their diabetes state as well, while concurrently improving their weight, which long-term reduces their cardiovascular risk, which is very prevalent in type 2 diabetes.
Okay, so we do have some semi-longitudinal data on long-term use with type 2 diabetes.
Yeah.
Okay, thank you.
Yeah, the GLP-1s for type 2 diabetes have been available for over 15 years, and I think we've got data going back 20.
But diabetes itself is such a significant risk factor. So again, if you think it's that compounded layer, now the question is just for those with obesity.
Correct.
Yeah. And the last comment I'll have on this slide is just that in that blue box, just kind of, this is evolving statistics, but right now, we're seeing about 35% of employers covering GLP for obesity management. Those that add it versus those that end up changing their mind after previously covering it, overall, it's still a positive trend that's going up, but that's the number that we're seeing. More commonly in larger employer groups than smaller. Next slide. Okay, so some of these have come out in the previous slide, and I just want to highlight a few things here. In terms of the GLP-1s targeting and based on FDA indications specifically for weight, Wegovy is the one that we're seeing most commonly being prescribed for those who are covering anti-obesity medication treatment, and that's a 15 to 16% weight loss, but that's only with around an 85% efficacy, meaning only 85% of those that are prescribed and stay on the medication actually achieve the 15 or 16% threshold weight loss. So that's important because it does mean that, there's at least 15% where even where we're prescribing it, even if they're tolerating it, even if they will benefit from it based on the clinical judgment of the prescriber, 15% of them may not be achieving that target clinically meaningful 5% weight loss. Zepbound or tirzepatide that will be coming on the market, achieves 20+% weight loss, but they're only achieving about 70%. And but they're measuring 15% weight loss as sort of their minimum threshold because they can achieve a significantly greater amount of weight loss. So these are factors to consider around prescription management and prescribing optimization. Lifestyle change remains essential. Both those studies that have looked at these, the maximum benefit was in conjunction with the lifestyle, and that's why the FDA indication is the treatment of and the use of GLP-1s in conjunction with physical activity, nutrition, sleep, and mental health, mental well-being, because they are all interacting together to impact nutrition and weight. To everyone's point, we need longer-term studies, and partly, we get that study through people using the medication post-release into the market, right? So the more data we get, the more utilization is how we find those rare but potential side effects that weren't discovered during the clinical trials, as well as other potential benefits that require large sample size. What we do know when people come off the drug, and we kind of touched upon this, is the effects and the benefit of the medication, specifically around appetite suppression, around delayed gastric emptying, all those return to prior baseline, and hence the weight will come back to a certain degree. It may not come back all the way, but it will reestablish itself if those medications are discontinued. And currently, what we're seeing is relatively high discontinuation rate amongst individuals using these medications in a sort of unstructured way. This is just data that people are collecting, so we don't fully understand how they're managed around the prescription intensive lifestyle, but we do see significant discontinuation rates. The last point to cover is we do know that there's increasing prevalence of obesity amongst the younger population. Type 2 diabetes used to be called adult onset, and that is no longer true. They are starting earlier. However, the complexity of obesity, especially in the context of family, social determinants of health, and all those other factors, there's still lots to learn and understand, even though the American Academy of Pediatrics has come out and said, GLP-1s can be appropriate for certain individuals in the pediatric population because of their risk factors. It's complex, and we're, improving a child's nutrition is obviously heavily dependent on the parents, so something to consider. Let me pause there. Thoughts, comments about this set of considerations as we think about GLP-1 coverage. Okay, next slide.
My comment is that it shows, and I think this was discussed, this is not going to solve obesity in America. If let's say it costs $5 a month, not $1,000 a month, so cost wasn't an issue, we still would have an issue with metabolic syndrome, cardiometabolic syndrome. We'd still have a problem with. It would be a helpful tool, but as you describe, a significant portion of people are unable to continue with the medications for a myriad of reasons. That potentially is in the 30 to 50% range, is my understanding. So it's one that we're always looking for the silver bullet, and this one's maybe half silver or something. But
fair point. I would consider this a very important and effective quiver in the physician's options of choice. If we go back to the continuum of treatment options, really this becomes that one additional option on the far right that is less invasive than bariatric surgery, right? So bariatric surgery has been around quite a while. We've gotten better at the procedure, so we're having less side effects, less complications, but it's still an invasive procedure that changes the anatomy permanently, versus this is another option that's equally effective. And along the same note, the safety consideration is just as important, just as it was for when we started to consider bariatric surgery. We need time, we need large sample size to really unearth some of the potential side effects and risks that are still not yet fully appreciated or understood. We obviously know the side effects are significant, and they're significant in both impact, but also the incidence across those who end up being on the medication. Now, doesn't mean that these need to be discontinued because of it, but that's why the importance of prescription management for those members who end up being prescribed these medications. It's not one of these things like, Tylenol, you just prescribe it and a simple bottle label, and the individual is good to go to sort of self-manage and self-medicate. Another important consideration is, you've probably heard, is around muscle loss. So here's the dynamic. If your appetite is suppressed and your gastric emptying is delayed, the impact is you're going to be eating less. And that's part of one of the positive impact that leads to the improved weight, but also improved glucose resistance, and insulin resistance, and glucose metabolism. That's so important. But when you're eating less, now the proportion and the choice of food becomes equally more important. So the muscle loss is a known side effect when you're reducing weight, that the body is going to be losing fat, but alongside that, the risk of losing protein, which is your muscle. And that leads to some of the terms that you've seen on Instagram, right? The Ozempic face and terminology such as that. It's really a misnomer, but the underlying dynamic that's happening is protein loss, excessive protein loss that's not optimal. So again, this is the importance of dietitians and nutrition and some support program focused on nutrition management and nutrition optimization to help that individual make better, smarter choices. Now that your quantity of food goes down, what's the right portion and how to make sure that you're getting the right set of ingredients to help you stay healthy. Again, this is not just about weight loss, it's about healthier metabolic state. So something to keep in mind. So again, hopefully we're highlighting that this is not just simply about whether to cover GLP, but it's really about how do we support members with these high-risk obesity conditions and cardiometabolic risk factors so that they can truly optimize and achieve improved physiological state. Next slide. And just to go over some of the long-term, my apologies, my screen just flickered. Long-term outcomes. So what are we hoping to achieve by offering GLP access for weight loss? Again, it's really about slowing the progression of the cardiometabolic disease complications, heart disease, stroke, kidney disease, et cetera, Improving weight also improves on some of the comorbidities, such as musculoskeletal symptoms, degenerative joints, right? So they are not directly causal from obesity, but there are complications as a result of obesity for some individuals. It gets hard to quantify, and the time frame really is multi-year, over a year, right? So this is not a 1 year. If I did this for these individuals, they are significantly better, which they are, but then does that translate to some financial return in the near term? That's very hard to quantify because the cost of GLP-1s are so significant. At $1,000 a month, that, pre-rebate, that's a very significant cost. And then to the point of to get optimal outcomes, it is about pulling all the levers that are available. The medication is, such as GLP-1, is significant. But then there's other things that we have to factor in, including creating an ecosystem for that member that helps them do and make those optimal choices, right? We work, we live in a community, and we have a home. All three have to be optimized and aligned. Otherwise, there's incongruence between what we're asking them to do, what the medication is doing, versus where their support and their environment allows them to do. So it is about lifestyle education. It is about improving overall family dynamics. So when we're improving one person's healthy choices, it should cascade into the other family members, and that's hugely important and impactful, specifically and especially for those dependents. So as we talk about, other factors to consider, keep that in mind that as we're specifically here talking about GLP-1s, it shouldn't be done in isolation of other things that OAB has the opportunity to impact and influence, and that it is really around the structure and the process of care around for these individuals that ultimately will achieve the maximum benefit and that's sustainable over time. So it is not just those who have the need now, but it's potentially those who are at risk of developing obesity over time and helping them sort of go on a different trajectory. Next slide. Let me hand this off. So who am I handing off to? Sarah?
I'm taking it for a while more. Thanks, Dr. Twang. So we're going to go over some additional considerations. These are things that we thought about as we were developing, and Kirsten will be going over some of the financial considerations. But as we're thinking about how much these drugs might be used, how much they might cost, these are some of the different things that we're taking into account. You've probably seen a chart like this before around the prevalence of obesity. Nothing surprising here. I think a couple things to note. We looked both at the national prevalence of obesity data There was some more recent data released for Oregon. 30.9% of individuals have a BMI over 30. That doesn't include the people who are overweight at that 27 or above. The Kaiser plan collects BMI as almost as a vital sign. They've got data on 58% of the membership, that 58% of the membership is identified as obesity 1, 2, and 3. So with 46.5% of the measured members having a BMI over 30 plus. When you include the overweight members, it's 77.5%. And so we looked at the Kaiser number, we looked at the national numbers, we looked at the Oregon specific numbers to try to really triangulate what the prevalence of obesity is. It is high, it continues to grow. And again, BMI is not a perfect metric, right, at an individual level, but at a population level, it gives you an idea of what the potential risk is in the population. We go to the next slide. So we talked about earlier about the unprecedented demand for the drugs, and it surprised a lot of us in the pharmacy industry. And I think it even surprised the manufacturers of the drugs as far as how many people are wanting to use them. So as a result, we've seen supply chain challenges globally. Wegovy, Ozempic, and Mounjaro, the three most talked about, and now Zepbound, they're all on the FDA shortages list, which means that your local pharmacy may or may not be able to procure some on any given day. And so those types of supply challenges can create disruption for members who are in the middle of treatment. And so that's a consideration for adding coverage, is what a member might experience in terms of being able to fill their prescription from month to month. And I've heard this from multiple employers on some of the challenges around supply constraints. We go to the next slide. Another consideration, of course, is equity. And there's a lot of different equity angles here. There was a lot of time spent in the summer research group on GLP-1s talking about the equity topic. This is just a sampling of some of the topics that were explored. We know, of course, that members who are experiencing obesity, they're facing stigma, discrimination. Movements like the body positivity movement have made some strides, but there's definitely still work to do. There's also differences in the prevalence of obesity and overweight by race and ethnicity. We also have to consider the social determinants of health and how those determinants affect the ability for an individual to change the factors that contribute to obesity or can make it hard for them to be successful in weight loss. And that's like what Dr. Chuang was talking about. It's the home, it's the workplace, it's the neighborhood. All of that can contribute together how well someone can be successful. And we also talked a little bit in the group about how offering better access to the GLP-1 drugs could improve equity for people that are experiencing overweight and obesity. But if it results in higher premiums and higher cost sharing, could that be an equity impact in the other direction for other people in the plan? So just so much to think about here. I think we could spend a day talking about the equity considerations. So I don't want to discount it. I want to say it's complicated and it's something that needs to be considered. If we go to the next slide. We struggled with how to categorize or how to even title this slide. But we wanted to put out there consideration, some risks in terms of the reputation of OEB and PEB. So a lot of us remember what happened with Vioxx back in the 2000s. Remember, it was supposed to be a drug. It was used for pain. It was safer than NSAIDs like ibuprofen and naproxen, but it worked as well or better. At least that's what the initial data and the clinical trials all showed, and it all looked good. And then the drug took off, right? Utilization exploded. Millions of people used Vioxx, and as that utilization increased, we started to see the emergence of dangerous side effects, adverse events. In the end, so much so, we saw so much adverse events from Vioxx, the drug had to ultimately be pulled off the market. It was deemed unsafe. And so as these GLP-1 drugs are going to be used in this larger and larger population, and again, we have data on diabetes going back 20 years, the data on the use for obesity and weight treatment it's newer. We don't have the long-term data. We don't have the huge populations yet. And so there is potential we could see emergence of more side effects, more adverse events. Most plans still aren't covering these. So is there a risk of being an early adopter of coverage? And that's something to consider. Also, there's the risk that OAB and PEB could experience something like what happened in Iowa or North Carolina. What happens if coverage is added only to be pared back or discontinued a couple of years later due to cost? And so that's something to think about. And then also, just as alluded to in that previous slide, there's the concern around equity and expanded coverage versus the impact of premiums and cost sharing for the broader membership. We go to the next slide. Yeah. So this one is about some of the complexity and nuance of the US prescription drug market. We just can't talk about how much these drugs cost without talking about rebates. And just to give a little context, the average cost of a weight loss drug, based on our anticipated market basket mix, it's around $1,200 for a 30-day supply. Average rebate back to the plan is expected to be in the 50 to 60% range based on what we know today about what the drugs are on the market and what manufacturers are likely to offer. It's meaningful. And as I mentioned earlier, the manufacturers are known to reduce or eliminate rebates if there's coverage limitations that are more stringent than what the FDA approved in the labeling. So for example, you could limit coverage to people with BMI 40 plus. That means fewer people would be treated, utilization would be lower, and the plan could end up paying nearly twice as much per treated patient. And I do need to call out too, Kaiser is unique because they're purchasing the drugs up front at a discount rather than having the rebate effect. So that's an important consideration too. Tom, you've got your hand up.
Yeah, I don't understand how, how they would know, how the drug companies would know that the individual who's, let's say, going to Fred Meyer's to fill their prescription is being supported by OAB versus being supported by Fred Meyer. Let's say they worked for Kroger or something. I don't know how that happens.
Oh, yeah. So the way it happens is when a member goes to the pharmacy, the prescription is filled, the pharmacy sends the claim electronically to the payer. The payer then invoices the manufacturer for the rebate. So the manufacturer knows which employer group or which plan is requesting the rebate for that drug.
Got it. Okay.
Yep.
Seems nefarious.
We can all have perspectives and opinions on how the drug system in the US works, but this is how it works. Yep. Okay, let's go to the next slide. The point with the rebates is we have to consider the rebates. We can't ignore it. It's a big consideration. Another consideration is therapy duration. So how long do people take these drugs? And we alluded to this earlier, right? Are these lifetime prescriptions? Or are these prescriptions where someone is going to take it for several months, and are they going to be able to maintain the weight loss after that? And what happens, right? What is the impact on overall cost if members are only taking the drugs for 3 or 4 months, stop, and then the weight is gained back? What has been achieved there? So that's something to think about. Potential for waste. There was one study that was out that showed only 34% of individuals that started GLP-1 for weight loss continue past a year. So there is this presence of side effects, treatment fatigue. People get sick of doing the weekly injections. People get sick of how the drugs make them feel. Even if they are achieving some of their treatment goals, sometimes people discontinue. And then also just think about the difference in unmanaged versus managed prescribing, and how does that lead to different continuation rate. So kind of like what Dr. Chuang was talking about, when we wrap around services, so it's more than just drug treatment, are members more likely to stay on the drug? Does it have a stickier effect if it's part of a larger treatment plan that's moving the members towards health? And that's something that needs to be monitored over time. We go to the next slide. We have to think about utilization, right? What is the uptake rate? So we know what the prevalence of obesity is. We can make assumptions along how long people are going to use the drug, but how many people are ultimately going to try? We saw the data from the Kaiser Family Foundation survey. A lot of people are interested. How many people want to go from interested to actually trying the drug? So how do you best match the treatment options with what the individual needs? And again, how do you make sure that the drugs aren't being prescribed to people who are metabolically healthy that maybe have a higher BMI due to body type? There might be some opportunity for accountability here through a lifestyle management vendor contract that can watch some of that prescribing and make sure it's consistent across the plan. We certainly know not everybody who is eligible for treatment per the FDA label is going to seek treatment, right? There's a lot of barriers. There's the drug cost. It's an injection. Not everybody wants to give an injection or is comfortable with that. And we talked earlier about the supply constraints. So ultimately what that uptake looks like depends on how the coverage is designed. Are members required to enroll in a lifestyle modification program like what Connecticut is doing and some other states, Florida? And if so, does that reduce the amount of utilization because it requires a little more engagement from the member? And if the BMI label of 27 to 30 is used, what does that mean in terms of uptake? Is there are a lot of membership there that could use the products. We go to the next slide. So these will go through quick. We just want to think about prices today, prices tomorrow. We can't ignore rebates and we can't ignore the prices either. Novo is making $4 billion in revenue this year. Ozempic is expected to bring in $11 billion. These are blockbuster drugs. They could become the biggest top selling drugs of all time. They are driving such demand, they account for almost all of the economic growth of Denmark, which is the home of Novo Nordisk. And there's been a fair amount of articles on that. Some of this might be, over the top, but it's worth considering. Dr. Willett at the Harvard H.T. Chan School of Public Health has warned that these drugs could potentially add 50% to the country's healthcare spending over time. And so we need to think about what the prices are and what does it mean in terms of sustainability overall to the plan, to the healthcare system. So that's prices today. Let's go to the next slide and talk a little bit about what could happen to prices in the future. Continuing to see some upward pressure, right? More demand, higher prices, they're new, supply shortages. I wish I could say pharma just decreases prices every year because they've made enough money, but that's not how this works. They often do increase prices every year by or more than the rate of inflation. Mitigating maybe some of those increases, the supply can work in either direction. Also, I talked earlier, eventually we're going to see increased competition. In a decade, we're going to see generics. Prices are going to come down. They're not going to come down tomorrow, but they are going to come down. And with the availability of new entrants into the market, we should see some continuing price pressure. So with that, I'm going to turn it over to Kirsten, who's going to talk how we looked at some of the financial uncertainty of these products and how we considered what the impact could be to OEB and PEB.
Thanks, Sarah. Before I jump in, I just wanted to do a quick touch base with Bill and Glenn because I'm noticing the time is 10:24.
So I was just thinking about that myself.
Yeah, so I didn't know if we wanted to take a break.
Here's what I'm thinking. Because we're about to get into the factor now that is what you're discussing, that we extend this to 11, because I think I was on the doula committee, so I kind of know a bit about that. That's going to be a lot easier discussion and pretty clear cut. And so donating a half an hour from the doula discussion to this discussion would take us to 11. And looking ahead on the slides, that should be okay, in my opinion. So if we take our break now and do it for like 5 minutes, and then give a half an hour for this is where the conversation's going to get back and forth in the next section. Is everybody okay with that? If we go from 10:25 to 10:30, come back at 10:30, and then get into the financials of affecting us. Is that okay? I see one thumb, right? My thumb, 3 thumbs. Okay, that's a majority. We're go. So break time for 5 minutes. Thanks. Counting down the seconds. We get a couple more cameras up before we say we're back in order. All right. See if Tom turns his camera back on. Kirsten, are you okay with 30 minutes? We can adapt.
Yeah,
Right.
for sure. Thanks, Bill.
Yeah. All right, why don't we go ahead and just start introducing this slide, come back to a session here and just introduce this slide. Go for it.
Great. So the last part of the deck talks about some financial estimates for some coverage options related to removing the exclusion for weight loss drug treatment. And it's been my experience that when we produce a number and share it, especially in a presentation like this, you'll see a big bolded number on a screen, and I think it can give the illusion that we're more certain about a number than we are. So I really just wanted to level set before we even start looking at some numbers around what do we know versus what do we not know. In the case of innovative therapies where we don't have a lot of history, or really in this case, the GLP-1 treatment for weight loss and obesity, we don't really have any information at all yet at this point. So most of this is what we don't know, and we've worked hard with the clinical team to put together a best estimate of what we think is reasonable and likely to happen. But as Sarah mentioned earlier on in the day, several other states who presumably have teams of people estimating costs as well put coverage in place, and then were surprised by how high the costs actually were in practice and had to rescind coverage. So the cost estimates that you're going to see, primarily revolve around estimated prevalence of overweight and obesity in the population. Unfortunately, obesity is largely undiagnosed in the claims data. So it's not something where we can just go into our claims database and look and see what percentage of OEB and PEB members are in each BMI range. So instead, what we need to do is look at some data that we have from Kaiser, some updated data from the CDC that looks at prevalence by state, which they collect through a phone sampling process, and try to extrapolate what we think might be the prevalence for the OEB and PEB populations. In practice, it could be higher or lower. We are also estimating the uptake rate. So for prevalence, somewhere between 30 and 40%, maybe even a little bit higher, of OEB and PEB members would qualify just based on the label coverage criteria. So that was the combination of BMI of 30 plus or BMI of 27 plus with a comorbidity for ages 12 plus. So just based on that criteria alone, maybe 30 to 40% of OEB and PEB members would qualify, but for many reasons, not all of those members would take the drug. That's what we call the uptake rate. So we are making an estimate of uptake rate. And again, that could come in higher or lower. Duration of therapy is a big question that we have. Some early indications are that people discontinue treatment relatively early, even though the drug manufacturers might say it's a lifetime therapy. In our estimates, we assume that if we were to just add up all the people taking the drug and look at how long they were on the drug, that an average duration of treatment might be 6 months out of 12 months in a year. There's some uncertainty around per script costs, net of rebates. That's especially important when we think about the timing of coverage now versus later. And then a big factor also is what would we wind up doing around cost share and benefit design, the affordability of the drug at the member level. We know when a member actually goes to pick up the drug at the pharmacy, the out-of-pocket expense will influence how many members take the drug as well. So when we do these estimates in the next few slides, we're assuming a typical cost share for pharmacy similar to the average cost share that we see for pharmacy drugs today, nothing special. And we also aren't assuming any sort of benefit limit on the drug as well. Maya, next slide. I know this came up earlier in the day, and this partly explains why we're in SEOW spending half an hour talking about finances of a coverage consideration when normally we focus on the clinical considerations. That's because for GLP-1 drugs, the costs are just a practical aspect of the coverage that we can't ignore, but also the clinical policy and how the coverage criteria is crafted to work with other clinical programs like lifestyle modification programs directly influence the expected costs and outcome of the coverage. So it just is a necessity of what we're talking about today, that we'll talk about finances. You know, so far, OEB has been successful at achieving a budget increase of under 3.4%. And that's a statute that we are now subject to every year. We talk about it every renewal, and we're going to talk about it again this renewal as well, because it really factors into our decision making. You know, 3.4% is a relatively tough standard to meet. For some of OEB's claim costs and PEB as well, we have some protection on trend because those claims are tied to Medicare rates, which tend to trend lower than commercial rates. And for OEB, that's about 24% of claims are protected through being tied to Medicare. But then for the rest of claims, those claims trend according to market forces. And I know we've all been reading in the news the last year or two. Inflation has been historically high. The labor market has been historically tough as well. So we already have some tough market forces that we've been facing last renewal and this renewal as well. So far, we've been able to manage to 3.4% through strategic decision making. So some decisions were made early on by the board to set aside some savings for future years. OEB and PEV have excellent care management. We also have innovative provider reimbursement schemes. So in a status quo year, we've been able to renew at 3.4% and not have any benefit cuts. But you'll also notice that we haven't been able to make any benefit enhancements that are material. And GLP-1 drug coverage, as you'll see, potentially has a cost impact in the 2% range. But it's not the only benefit we're talking about this year where this is going to come into play. We've also been wanting to, for several years, shore up our family building benefit and enhance it to include coverage for artificial reproductive technologies, including IVF. And currently, the formula is a 1-year test, and we don't have the ability to factor in long-term savings. So it is a consideration as we think through how to offer this coverage for OEB and PEB and also still meet 3.4% without offsetting through what would be pretty extreme benefit cuts. Just to set the stage, next slide. So I just wanted to highlight the cost share dynamics. In particular, for OEB and PEB, the cost share is pretty different. And even with OEB, depending on if we're looking at the HMO and PPO plans or the HSA plans, the cost considerations are different. These impact the member at the member level and are an important consideration in equity when we're talking about adding coverage. And I think it's implied, although we don't always explicitly talk about it, adding coverage also means adding affordable coverage that is accessible to all different types of OEB and PEB members across the state, not just certain members in certain plans. So I just wanted to high level touch on the different pharmacy cost share scenarios that we have out there. So for PEB is easy. PEB currently has a copay, a relatively low copay for prescription drugs, and they don't have an HSA plan. So we're not thinking about how the deductible interacts with that benefit design. For OEB, we have most of our plans are non-HSA plans, whether through Kaiser or Modus PPO plans. For Kaiser, there's currently a $25 brand copay. And then for Moda, there's a copay cap of $75 that members would wind up paying the $75 for the weight loss drug. For OEB HSA plans, the conversation gets a little bit more complicated now because we're looking at members having to meet their deductible before they get the benefit of coinsurance and helping to pay for that drug. Rebate considerations come into play here. Rebates are passed along through lower overall premium for all members, not at point of service. So it's a benefit in operational detail that we'll need to work through with the carriers. in making this affordable for members at point of sale is bringing in that rebate offset at that time. So for members on an HSA plan, presumably the cost share of a weight loss drug prescription would be around $100 a month. And that's not factoring in coupon availability. There is a coupon available for Wegovy. It's $225 if a member is insured, and everybody we're talking about today with OAB and PEB, they have insurance, of course. So the coupon would be $225, which would pay for these expenses. So potentially no out-of-pocket member cost. Maya, next slide. So just to talk about a couple different kinds of cost impact, there are really three. So for a member, I'll actually start at the bottom one. So for a member taking this drug, presumably they would need to go to a physician to receive a prescription for the drug. So we have the physician office visit cost, and then also the member copay, the drug copay, to the extent the member hasn't already met the out-of-pocket maximum, and to the extent the cost isn't paid for by the drug coupon. And then the cost of the drugs, however much of that we are not able to offset, if that were to flow through into premium, it would increase premiums for all members. And then depending on how the boards decide to craft a long-term strategy for funding this initiative, if that involved any sort of benefit change, the members impacted by that benefit change could have a higher cost share as well. Maya, next slide. All right, so I want to start with two high-level slides. The idea here is not to have any sort of shock value, but really just want to illustrate, the slide that I talked to a little bit ago around financial uncertainty. And financial uncertainty, really costs could come in lower than we expect, which would be helpful. The scenario we're more concerned about, I think, is that costs come in higher than we expect, and we're put in a position of looking at rescinding or altering coverage. So in this slide, and then the next slide right after this takes a similar look at PEB, we're asking ourselves, what is the upper limit for costs if in some scenario, everybody who was estimated to be eligible for the drug, and there was some uncertainty around prevalence of obesity that we talked about, but if everybody took it who was eligible, what kind of cost impact are we talking about? So for OEB, that would be around 45,691 members would be eligible for the drug. We're assuming an average net cost of rebates between $500 and $600 and an assumed duration of therapy for 6 months. So based on those three assumptions, the estimated OEB cost would be around $140 million a year. And it just highlights, in so many ways, the GLP-1 coverage discussion is unique, but never have I, in my history and working in healthcare insurance, talked about something that impacts so many members that is also high cost. It really makes this conversation unique. And then if we look at the third bullet point, if 15% of eligible members took the drug, the OEB's annual expenses would be around $21 million a year. The 15% is Mercer's best thinking at this time. It's around $21 million, 2.3% of premium. All right, let's see what it works out to be for PEB on the next slide. PEB has some different dynamics than OEB. I called those out on the right if you're curious. Just a couple little different things change the scenario for PEB slightly. But if we take the same look, 100% of PEB's estimated eligibles took the drug, that would be about 44,762 PEB members at a same average cost around $500 to $600 per script for 6 months of the year. Costs might be around $143 million a year, which is 12.6% of premium. Our best thinking on uptake is that only 15% of the population would take the drug, which would reduce the annual expenditures to $21.5 million, which is about 1.9% of premium. Maya, next slide. So we have a couple coverage options that we're going to look at, and a primary consideration that is shaping all of these coverage recommendations is something that was discussed earlier on the call, which is really needing to protect rebate eligibility because it is such a substantial factor in cost of the benefit. So if we were to have any sort of coverage policy that was not in alignment with the label and we lost out on rebates, that average cost per script would more than double. So just in terms of sustainability of this benefit long-term, we need to look at coverage options that are variations, but still also are in compliance with the label. So this is the base scenario. So this is not the base coverage scenario. This is a scenario that Mercer wants to talk about and introduce, and just to make sure that it's on the table. I know we've acknowledged member feedback and the desire and urgency around coverage. I think, we've talked a lot today about new therapies coming to market and potentially having lower costs for our members. We've also talked about the importance of offering coverage in the context of a lifestyle management program that can help members maintain over the long term gains that they've had while taking the GLP-1 drug, so that they have time to realize those long-term health benefits that don't start to kick in until years 5+. So the Mercer clinical team was talking about how to do that, how to make sure that we offer this drug with a robust wellness environment around it to set our members best up for success. Our thinking was that 10/1/24/25 plan year, the next plan year for OEP, could be a readiness preparedness year where we're rolling out new weight loss vendor options, emphasizing health coaching, and really focusing on educating members and helping members understand the permanent lifestyle changes that would be needed to sustain improvements with GLP-1 drug coverage of weight loss, and then looking at actual coverage implementation for the following plan year, which in OEP's case would be 10/1/25/26. So it's just something to think about. That's why there's no cost impact for this scenario for the upcoming renewal. Maya, next slide. So in this scenario, this is what I meant to say for this, the base scenario, which is really covering according to the label only, but without lifestyle modification. So in this scenario, we're thinking 15 to 20% uptake of the eligible members, and the eligibility criteria is outlined here. As well, it's the same thing of BMI 30+ or 27+ with at least one comorbidity. Age 12+, but within there, we want to emphasize the role of the prescribing physician and making sure that the member is appropriately taking the drug, and also applying, for an exception for a member who may need the drug but doesn't qualify in terms of BMI. The expected annual cost for that uptake range would be 21 to 28 million for OEB, 21.5 to 29 million for PEB. As a percentage of premium, 2.3 to 3.1% of premium, and then for PEB 1.9 to 2.5%. And in this scenario, we are retaining rebates. Andrea?
So in the expected cost, is that based on the 6 months a year?
Yes.
Or is
yep.
Oh, okay. So that potentially could double. I mean,
yeah, it probably wouldn't double because we always have new members coming on the plan and off the plan, and it would take members maybe a while to get into their physician and receive a prescription, but maybe it could be as high as 9 or 10.
Okay, I just meant like if they do 6 months, it could be that they end up on 12 months
in the future.
Yeah. Okay. Yeah, thank you.
Agreed. Mm-hmm. All right, so let's look at the next scenario. So it was initially back at the very start of summer when we kicked off the weight loss drug work group, we were talking, acknowledging upfront the tremendous cost of the benefit and trying to think through how can we get some level of meaningful coverage to OEB and PEB members if we need to phase this in over multiple years due to costs. You know, and the thinking at that time was maybe we can roll the drug out to our most acute members who would potentially have the highest clinical benefit the soonest, and then phase in to lower BMI over time. So we looked at a couple scenarios at different BMI levels, but it just doesn't make financial sense. These are off-label scenarios. In other words, now we are having coverage criteria that is not in alignment with the drug label, and so we lose out on rebates. And the cost modeling just doesn't show that that scenario saves any money. So you can see for BMI 30 and BMI 40 plus, the cost range for OEB, we're looking at 29.1 million versus 16.8 million for BMI of 40 plus. And you can look at the number of eligibles. It's because we're cutting the number of eligibles in half, basically. And then for PEB, the two estimated cost impacts would be around 30 million and 17 million for those two scenarios. Hi, Tom. Yes.
Yeah, the only protection it gives is if your 15% estimate, 15 to 20% estimate of all comers is low. If it turned out to be 30% instead of 15% utilization, you know, you'd be, you know, way up. This one, but I agree with you. I understand exactly what you're saying, and I don't. What I don't know is how firm the drug companies are in the scenario of if you don't follow the label, you don't get the rebate. It's just something I have no experience with. So, you know, it's where I trust, you know, our consultants to tell us what's the most likely scenario.
Yeah, I can take that briefly. We are trying, and we're trying very hard on behalf of a lot of our clients to try to get some movement, talking with the PBMs, especially some of the big PBMs in the market, to really press for some additional flexibility from the manufacturer. To date, the manufacturers have held firm that they're not going to offer rebates unless the drug is used and offered to everybody who meets the labeled requirements. This isn't new to GLP-1 drugs. We've seen this with a lot of other drugs in the market too. So we're pushing, but so far they're not given an inch.
Yeah, thanks for raising that issue, Tom. We talked about that also last renewal with Humira. I think it's frustrating. Maya, next slide. So if you remember when Sarah was reading the label for Wegovy, it had that preamble at the beginning about that, hey, this drug should be used as an adjunct therapy to lifestyle modification. So we can actually look at the scenario of adding coverage exclusively through a lifestyle modification vendor as an option that would help. Really, the focus here is not so much on reducing costs as it is really trying to ensure that members have sustained outcomes, which over the long term would reduce costs, right? Because now we're not having members churn on and off the benefit because they're not sustaining the results. So this would have a long-term benefit. Lifestyle modification means exercise and nutrition. Dr. Chuang also emphasized other aspects of wellness, including mental resiliency and sleep, that are rolled up in that. We don't have a lifestyle modification vendor today to suggest that's something that the carrier partners, we would work on with them during the renewal. So in this scenario, members are actively engaged with the lifestyle modification vendor while they are taking the GLP-1 drug, and there would be some sort of authorization process at the beginning and then also ongoing during therapy. In this scenario, maybe utilization would be slightly lower. Maybe some people would not have an appetite to change their lifestyle. So we have utilization uptake of the drug at 10%. We are still retaining rebates. We do have a slightly longer duration of therapy assumed in this scenario, though. If a member is supported in their effort to take this drug and their symptoms are being managed and potentially they're having better results, maybe they'll stay on the drug longer. So in this scenario, we're looking at a duration of therapy on average of around 9 months. So the cost impact for OWEB would be estimated to be around 21 million, and then for PEB around 21.5 million. So Maya, if you go forward one more slide. Oh, hi, Tom.
Yeah, the do we know whether or not we'd run into trouble with geographic availability of the lifestyle modification vendor, or would it be, you assume it's virtual? And the other, and again, I don't expect answers now, this is parking lot, the issue around that lifestyle modification vendor, it would need to be put through the health equity screening process to make sure that it met the needs of our diverse people we care for.
Yes, thanks, Tom, for bringing up health equity. It will go through the health equity committee. In terms of geographic availability, we are assuming that it would at least contain a virtual component, if not also an in-person component. We just met with the state of Connecticut to understand how they've rolled out coverage for their state employee plan. And they have a combination of a virtual provider for their adult population with a local bricks and mortar solution for their pediatric population. But it's definitely on our mind, the geographic distribution of OWEB and PEBS members and making sure everybody has equitable access.
Thanks.
We are right on time. Maya, next slide. You did a good job estimating, Bill. So in this scenario, we just are asking the question basically, how might we offer coverage for 10-1 in a financially sustainable way? We just talked about, we also want an outcomes sustained way, right? But we also want a financially sustained way that doesn't lead to unintended consequences of having to decrease benefits for all members or things like that. So we're just contemplating rather than recommending different ways we might approach that. Again, more as a phase in and a way to take in, open the door to the benefit and refine it over time. We could have a higher cost share on the weight loss drugs. We could also have an annual limit or lifetime benefit on the drugs that would influence. A lifetime benefit influences churn coming off the drug and back on the drug, and just getting short-term benefits each time. We also, there could be global benefit changes as well, but just given the cost that we're talking about, around 2% of premium, we'd have to make pretty hefty deductible and out-of-pocket changes to pay for that. So it's just something, we'll talk more about that depending on what the SEOW committee thinks and what's discussed at the board. We have the whole renewal process to work out details like that. So my last slide. So I know we've talked about a lot of considerations today, and they really are considerations, and I'd frame this slide as a consideration also. It's just food for thought, no pun intended. Really, as we've explained, I think Mercer's recommendation would be to focus on readiness and preparedness in year one, to really make sure that when we do add coverage and commit to those costs and make an investment in the coverage therapy, it's successful for as many of our members as we can make it, and they have long-term sustained outcomes. If we do need to go ahead and offer coverage for 10-1, again, focusing on maximizing outcomes and reducing the needs for members to try and fail, but really just come into the program and have sustained outcomes for the long term, we recommend coverage within the context of a lifestyle modification program. That's it for Mercer's slides.
All right, thank you for the lengthy and well presented, lots of details here, as you pointed out at the beginning. Kind of funny, I was texting my team's advocacy leader during some of this, especially at the end, and there's definitely a lot of comments that were brought into play as well that we didn't discuss here, public comment, but I believe we all had access to read them. They were very one-sided. And I'll open the floor up. Sarah, I see, is that Sarah? No, sorry. Glenn, you have your hand up.
Oh, I was just going to ask if the SEOW members wanted to, we've gotten a number of different options from Mercer. Is there another option that they would like to also be considered with these options, that they would want to get some more information or research done on?
For me, I can tell you that the team I represent is on this slide in the alternative option, with really the focus on being fully compliant with the label and ensuring that we get the rebate options as the rebate is there. I know that can all change, and these numbers are all estimates, and that's why we have Mercer here to give us the best estimates we could possibly get from the actuarial perspective. But the push for this, kind of drives from 50 plus years and more than that in our culture of pushing that obesity is and food quality and how you should be the number one approach to healthcare. And this was bound to happen, that somebody was going to come along with a group of drugs like this, and kind of the thought that that's what we pushed in there, and so that's what we lean towards. And this is going to be a slow roll, a learning process over years. Whether we start this year or next year, it's going to have the same problem where we're going to have a long learning process, not just as OWEB and PEP, but as a country as we go through this.
Yeah, I agree 100% with what Bill just said. I don't have I think the work group and Mercer has laid out the appropriate number of alternatives. I see them as 4. There's the defer for a year while you spend time building the understanding and building the infrastructure, and then of the actual, okay, we're going to do it. There's 3 different options. One is the offering it without the intensive lifestyle management, with the intensive lifestyle management, both of which under the approved label, and then finally limiting it to high levels of obesity. And I think those obviously need, I don't see the need to add additional options there. I'm interested in hearing Andrea and Greg's thoughts also. But from a SEOW standpoint, I don't see the need for additional options.
I'll make a comment to that after Andrea goes, and then Greg.
So I think the options are good. I mean, I think those are appropriate. And I do want to think, I know that we've had public comment, but I do want to look at Mercer's recommendation of the deferment, only because I don't think it would be fair to our members to start something without having a program in place to support them, and have that fail, rather than, I mean, of course, I'm an academic, so I'm a researcher. I want the, evidence. So I think that, but it is hard, but I think that these are probably the best options that we could have.
On the same line. I mean, for me, something new like this, be it a drug, be it a new toy, be it a new game, I find it, I use it, and it starts to work for me. And I tell the 500 people I work with at work that it's doing well, and the next thing you know, we're $50 million in, or $500 million in, and yeah, maybe only for 6 or 8 months, but that really puts a huge dent in what we were trying to do. And so I know from PEB, when we were looking at it, we had a limited amount, which this is great to have this much information. I appreciate it. And we, at this point, we're looking at more of a deferral to get a little more information on where we are. It's, you know, at this point, Mercer's done a great job and giving us their best thought. And at this point, it is, because it's so new, you know, nothing against them at all. It's a thought, and we're not sure where it's going to go. But they've given us a lot of great information that we can start with, that's for sure. And I want to thank them for all the research they've done in this, because it is a huge brand new field that there's not a lot out there, but they have gathered quite a bit of information in something that we really 6 months ago had absolutely no clue what it was, and now everyone's talking about it. So I want to thank them for that, and the committee that went through this. And we have some months to go till we need to actually make a decision, you know, but I think it's going to be a big decision for us either way. So thank you.
So I'll chime in what Tom said. I don't think, for me, the options are all good. I like that, and I've already expressed the one that I would be leaning on based on the facts of what was presented today. What I find that I would like to have more information is if there was a managed care for the membership to go through to be approved and get their prescriptions for a GLP-1 with weight loss, that we start not defining, but at least talking about the components of what that would be. So, for example, things that would come into play, you know, what type of access would the membership have to that care manager? What kind of criteria? In other words, what would the member need to do? What kind of tests? What kind of things would be done prior to that? Length of prescription, for example, if you're going to have a participation requirement, which is what I'm showing here in this alternative, that you do 3 months prescription, not 1 year prescription. So your renewal is based on your participation in the program. Those kind of criterias that we're looking at here, that we would define to select a vendor to manage this prescription program for us, to mitigate those who are just doing it for whatever, because my friend said to do it. But there's some commitment to actually wanting to improve your health. You're willing to participate in the program, and the requirements we would put on the selected vendor to administer the program, what would those be? And that's kind of what I would like to see under the alternative option. What are those requirements going to be, or not going to be, but suggestions or ideas, concepts? Does that make sense?
It makes a lot of sense. It's not just like I said, it's not just a free for all, you know, because of what this is going to cost and where it's going to go. I think that's exactly what we need to do is, you know, you need to be committed to doing this, because once you go off of it, you know, do you go right back up again? Then do you get to go back on it again? You know, those are things that need to be set out there for.
Exactly, and that's another criteria that we want to list here is how to manage people who are flippant about it. You know, there's some cost structure here, you know, especially with the HSA that will also there, but there's some mitigating factors. You know, for me, I'm still thinking, okay, I'm gonna stab myself once a week. I'm questioning that, and I qualify for this based on the label, and I'm just like, really, right? Because I'm in that category that qualifies, but all my health numbers are dead nuts in the middle, like right smack in the middle. So not having a problem. So why would I want to stab myself once a week? Anyhow, that's my thinking. I know we're 10 minutes out. We do want to talk about doula, but any final comments? Again, this data here was presented for all of us to think about. It's going to be presented again this afternoon in front of everybody. I don't think we made any major comments here in SEOW that would change what is being presented, in my opinion. But final comments in SEOW before we go through a little bit of doula discussion.
Just to talk about what we're going to, you know, about the board presentation, we will be honing it down. We will not be having this level of conversation. even though we were talking about the same thing, the same deck, what we were able to do today was this morning was, from my view, absolutely critical, because the board can't do what we just did. You can't get into the detail and have the conversation and sort it through. So from looking at it from the board's perspective, the richness of this conversation is hugely important and will set us up, set the board up. And so the board standpoint, as the chair of the board, my appreciation goes to the carriers for their participation in the research, OHA staff who supported this, definitely Mercer for pulling it all together, and for the four members, 2 from PEB, 2 from OEB today, discussing this. Hugely important, and thank you very much. And I'll shut up so we can go on to doula.
All right, so into doula. I'm not sure who's presenting. I can tell you I was on the committee for doula, and I learned a lot of what I thought I didn't realize I didn't know, right, about this particular topic, and the birthing experience. So it's surprising to me that how much was learned. But let's go through this.
Bill, it will be Christy Ewing from Mercer.
Great. Thanks, Bill and Kirsten. All right, so I have the pleasure of speaking with all of you about doula, and hopefully we'll have such a rich discussion about this as well. So also this summer, let's go, Maya, actually to the next slide, please. So first I'll just give some background and then we'll talk into our considerations. And so Maya, if we move to our background slides, our goal for today is first to present to you this information and then really find out if there's additional information that is needed from all of you to really develop or forward a recommendation to the board. If there's enough information and you feel, you know, that we can talk a little bit more about what that recommendation would look like, which we do have some also recommendations for everyone today. And then also then talking about what that decision is that we want to move forward to the board. And so as we move into the next slide and just talk a little bit about the background. So with the same as the GLP-1 conversations this summer, SEOW also convened a research group where we really started talking about doula coverage and really what's happening right now, as there is a lot of traction around doula services just because of the benefits and that it is happening in multiple states. And so the research group was charged, you know, really with, first of all, diving into the research and what is doula coverage, what are those definitions, and then also looking at coverage options, you know, what are some of the challenges, what are the pros and cons, and really the outcomes and effectiveness. And just to say, you know, right now that doula coverage is not currently offered under OEB and PEB plans. So talking a little bit more about what is a doula. And so in the context of what we looked at, we really are talking about doulas that are for the full birth experience. So prenatal, birth, and postpartum. And a lot of the research showed, you know, that postpartum period is up to 1 year post-birth. Birth doulas are non-clinical. They are trained professionals, and again, they do provide this support of physical, emotional, and informational support to the birthing person. And again, it's before, during, and after childbirth. And then specifically in Oregon, doula services is offered through Medicaid, and the certification is required as a traditional health worker. And there is a very concise curriculum that needs to be completed, and it does need to be an OHA approved curriculum. And then doulas do need to enroll in the state registry. Any questions about background or what we're talking about here as far as doula services?
I'll make one quick comment. Something that was presented by the doula group. So this is obviously the statement is biased, but I found it interesting that, as they said in the birthing room, the doctor, and this is not slighting the doctor, but you know, basically the birthing room people are focused on the health of the baby, with of course not threatening the life of the mother, whereas the doula is focused on the mental health and the situation for the birthing parents, is focused on them. So there's an advocate for them, and the amount of change it does in C-sections and episiotomies and things is dramatic when you have an advocate that's on the side of the birthing parents and not totally focused on the health of the baby. I'll stop there.
Thanks, Bill. I appreciate that. You're right. That is exactly, again, really that advocate for the birthing person, helping communicate to the clinical team. And also at times when, you're in the midst of labor and delivery, being able to communicate also the birthing person's wishes and desires. So such an important component. All right, so let's move, Maya, to the next section. So talking about, we're just going to go over through some of the considerations in the research that we looked at. So looking at first some benchmarking, and again, I said this is such an emerging coverage and benefit that's being offered. So currently there's 11 states that do offer doula coverage. There's actually 8 also right now that are in the process of rolling out doula coverage. And when we looked at what's offered as far as the Medicaid coverage, it does really range. And so there is anywhere from 2 visits up to 12. And then in addition to those visits is the time for the birth and labor and birth. And so you can kind of see here, what that looks like for these 11 states. Oregon actually falls within, it has 4 visits. But the interesting about Oregon is that with the 4 visits, there is actually one of the higher reimbursement rates for doulas. Also, then when we looked at the commercial doula coverage, couple things here that you can just see is that, so Providence Swedish does have a great program in Seattle that they offer. You can see the fees range depending on the experience of the doula, and a little bit about what that program is. Within our Mercer Health and Benefits Survey, we are finding that larger organizations with 500 or more employees, 23% of them are really having some type of coverage, whether it's for doulas, midwives, or birthing centers. And then one state, Rhode Island, does require doula coverage in its fully insured private insurance plans and also as part of their Medicaid plans. All right, and moving on to the next slide. And so health equity comes into play here. So it's interesting, right? Doula services, and we'll show in some of our following slides, is solving some equity pieces. But also within the benefit, there are equity considerations that we wanted to make sure we were taking into consideration. And so a couple of those are lined out here. And so, first of all, just looking at the doula network, it is a new, it is a newer service that's being covered. So, can the network meet the demand? One of the findings of the Innovation in Medicaid report that just came out for 2023 also really showed that it was important to partner with community-based organizations, use doula hubs to really help support doulas in, kind of navigating the system. And then also recognizing that sometimes funds are needed to recruit and train doulas. And then also the diversity piece of that network is really important. We know that in equity considerations that doulas are really making a difference in the clinical outcomes of diverse populations because, again, they are advocating and providing that support to the birthing person. Also, some other considerations here is just within the plan design, we really want to make sure that the plan design is supporting the needs of the birthing person, but also the needs of the doula. We know from the research that doulas spend about 32 hours of direct care time with the birthing person. And so we want to make sure that we have a benefit set up that is going to be equitable to that doula and the time that they're spending. Just in the reimbursement process, wanting to make sure that the reimbursement rate is fair, as I just shared, looking at different ways of doing that reimbursement, and then just considering different reimbursement methods and making sure that that's not a hardship on the doula or on the birthing person. As far as some of the states in the commercial plans, or some employers are also, they will have their member pay out of pocket for that doula, and then they can get reimbursed. But obviously there's equity considerations in that as well. In the reporting, it's just really important to make sure that we're collecting the health equity metrics so that we can see the impact that doula services are making on different populations. And also it's really important for doulas. One of the great services that doulas offer is to help connect the birthing person to resources within the community and really be that conduit. And so we really want to make sure that we're tracking what those referrals are and showing the value that the doulas are serving. And then finally, in communications, just really wanting to make sure that program communications are accessible, and that there's another piece was that we want to make sure there's collaborative relationship between the clinical team and the doulas. Moving on to the next slide. So some of the clinical considerations. So this first bullet up here is a theoretical cohort that Oregon researchers applied and really showed that the impact that doula services could have in this cohort. Across the research that we found, and most of the research is with the Medicaid population. And so, it just really shows that across the board, there are so many positive clinical outcomes. So, you can see here it impacts C-section deliveries, preterm births, decrease in medications, overall, just fewer negative birth experiences, decreased rates of postpartum depression. Again, this is really for that long-term after birth and labor support. Tom, I see you have a question.
Yeah, that bullet point is very difficult for me to understand. It doesn't describe, is it the population of Oregon? Is the population of Oregon Health Plan? Is it the world? Is it the United States? It doesn't give any time frame. Was it in a year, a month, a week, a decade? So that bullet point is to me meaningless because there's no context around it.
Thanks, Tom. I appreciate that. We are trying to, so there's, as far as gathering data within Oregon, I think that's where, again, this is such an emerging coverage. So I'm trying to give some, I guess some feel about within Oregon.
I used footnote 1. If you look at footnote 1, it gave me a bit of context.
Yeah, well, my screen is too small for me to be able to see that.
It's a cohort of 1.8 million women. These are the numbers out of that cohort.
Of deliveries, of births. I mean,
yeah.
Come on. What I'm saying is if we're going to throw data at people, let's have it be something where you give the context. It's
Thanks,
again,
Tom. It's
a pet peeve.
I'm happy to follow up and provide more information for that, for sure.
Just, fix it. That's all.
Yeah.
Eventually. Yeah. Thanks.
Yep. Thank you. So you can see here again, just this, so many positive clinical outcomes that come from doula care and the services that it provides. So if we move Maya to the next slide. And so we did a lot of research and we actually met with Oregon Health Plan to hear about some of the learnings from the program. We looked at also there is a recent, again, the Innovation of Medicaid Learnings just came out with a recent report that did a learning session with all of the states that are offering doula services right now. And so in all of that really deep dive research, we, determined that, really looking at 2 different kind of visits. And so this is option 1, 4 visits plus the birth and delivery. So that's currently what's offered in Oregon through Medicaid. So that's why we wanted to include that. We did hear from OHP, and also the research shows this, that 4 visits is just not enough to provide the support. And that, again, doulas will spend more time in direct care. So there's that equity concision there. Option 2 is really what we found that is kind of the a good visit account that does get to those clinical outcomes, that does provide more of that direct patient care for the doulas to be reimbursed for. So option 2 is the 8 visits total plus the birth and delivery. You can see here, so what we did is as we looked at net costs, and that's what's represented here as these net costs as the cost impact, is we used in option 1, the cost of the doula services for those 4 visits, again, with those $215 per visit plus the $640 for the delivery. Same thing with option 2. And then we used the 30% reduction of C-sections and a 20% reduction of preterm births as a savings. And then talking about a utilization of 15%. So saying that within the population, about 15% of members would utilize doula services. And so that's how we got to this net cost impact. So you can see here with option 1 that there is no net cost impact. And with option 2, it's a 0.01%. I'm just going to pause. Any questions about that, of how we got to this net cost impact?
I'm not sure if those numbers mean that there's a very efficient system that's operating here, or we need to dramatically increase the birthing rates in this country.
My comments on the and when the 4 visit versus 8 visit, it's kind of hard with 4 visits to understand how you provide any substantial postpartum care. So I'm definitely fall towards the 8 visit. The costs that you have used, the decrease in C-section and the decrease in preterm, those are not guesses; they're estimates. They're fair estimates. And my guess is that you're not including long-term, the impact of long-term care around the preterm baby that has increased issues, not just in the neonatal period, but over the next 5 years. So these are the problems with making estimates are that there's about 100 different factors that are in play, and the fact that we have agreement that the changes are essentially a wash and has the potential of huge long-term benefit is pretty supportive of us exploring this. Trying to figure out what the actual number of reductions of prenatal of preterm babies, that will be pretty clear. The C-section, the complexity there is, half the C-sections are done because someone's already had one. Well, you're not going to reduce that number substantially. It's the initial first pregnancy that you're hoping to make an impact, and subsequent ones where they had a vaginal birth the first time. So again, complex financial monitoring estimates are fine, and the fact that 1 and 2 come in at essentially a wash with pretty reasonable estimates are I'm pretty happy with. when I saw this, I kind of went, yay.
Yeah, the committee was at option 2, just so you know.
Yeah, well,
that
of
it
course,
needed 8.
of course. I agree. I agree with option 2 because I don't think that I think a lot of the long-term improvement in health is going to be having that support around the postpartum period. And I just don't know how you do it with significant postpartum support when you have 4 visits.
There was also good data on the improved mental health of the birthing parent as well, right?
Yeah, I got it. I got it. Yeah.
And just so you know, Tom, like you were saying, like 5 years down the road, most of the doulas and most of the research that we looked at, they're basically just through that postpartum part, and then also some of the breastfeeding part, and then at that point they're pretty much done. And so there's not a lot down the road, but a lot of the stuff that we looked at, which I was on this panel as well, I think it's we were definitely option 2, and I think it's something that we need to really look into giving.
Yeah, be very interesting. Yeah, it'd be fun to watch over time. And also, I think the one of the most challenging aspects of this is going to be how you used for your estimate. Again, estimates are all that we have. Is a 15% uptake of the doula process, and that the first year it may be, the first month there'll be less, and 6 months in it'll be higher, and 12 months in it'll be higher. It'll be fascinating to see how doulas are integrated into the medical industrial complex.
There were some interesting testimonials during this process. One that will be remembered by me for a long time was a woman who was basically stated that in the middle of the birthing process that she lost the ability to speak English. She went back to her native language, and if there was, she couldn't understand English, she couldn't speak English during that time, even though she was a fabulous English speaker. And if there wasn't another person in the room who spoke Korean, there would have been difficulties, right?
Fascinating.
Right. And that's just one that we remember. There was many testimonials, but that was a classic, right?
Yeah.
Yeah, I think it is. It's such an impactful coverage and making an impact on the members.
Yeah. And the one that was quite common, the one we all know, is when a birthing parent is relying on a child to translate some of the more technical stuff for them is never a good outcome, right? Let's be serious, right?
Yeah.
So
hey, I came to Oregon in 1980 and worked at a migrant farm workers clinic, and I was in those situations, late at night, phone calls and things like that. So I get it.
Our committee was set on option 2, and it seemed pretty clear. I mean, there wasn't really a whole lot of discussion once the data came in, right?
Yeah.
So,
and I would just like to add as an uptick that I was on the committee that came in much lower than the other committee for a price point to our plans.
Good.
So I don't know, in the afternoon meeting, should SEOW make a recommendation for option 2 on this one? Can we just go ahead with that?
Bill, from a technical standpoint,
we don't have a quorum.
It's just the 2 of us. So and
so
there isn't there's not a need for us. I think that we can foreshadow the recommendation by adding in Greg's voice. And Andrea, I assume you're also in favor of option 2. Maybe I'm.
So that will that be stated in the Mercer report that the committee was?
No, I don't. We'll just add that.
Okay. All right. Okay. Glenn.
Well, I was just going to agree with Tom. I think because of the quorum issue. And also what we can do is what I was planning on doing was sending these presentations in the meeting recording to Sue and Robert, so that way they can review and then provide if they have any questions regarding either one of the presentations prior to January.
Alrighty. Hold on, I'm going back to the top of my notes here. Not notes, but okay. Meeting recap is, hey, we went to 5 minutes ahead of schedule. How'd that happen? Right. So I don't, meeting recap. We went through a lot with the GLP-1. Tom, you expressed what's going to happen at this afternoon's full board meeting from your chair. I think it's important that we make sure make sure all board members are understanding that we're presenting today for requests for additional information and a probable decision in January to give guidance, that everybody knows that's what we're doing. I know we had some sidebar discussions about the reserve funds and things of that nature. Those are important for all the board to understand how that will play, how that can affect your decision making, and that should be brought up as well, in my opinion, from SEOW, because that's part of the efficacy, is just how we have those reserve funds sitting there as well. Ollie, your hand is up.
No, you just actually answered my question. I was just going to ask if we should talk a little bit more about the reserves and the status of the reserves, and then I can even talk a little bit about the 3.4% test. So
we will actually in our renewal primer, the board members will see the reserve funds. So it's actually and we start with that. So the reserve funds will be they'll understand, the board members will have seen it just before this presentation. So raising the issue of how we spend the reserve funds, that this may be one of the ways we do it.
I forgot to look. Was there a reminder in that? I'm trying to remember when I read it on how we did the reserve funds last year's renewal and how much we bought down.
Yes,
for how much
it's included in it.
It's included in it, right? Okay, I thought there was. I just couldn't remember.
It's included in the.
Just so people remember how it worked. Right.
Yep.
Perfect.
Okay, great.
Yeah, so we'll have that.
Staff, any other review of what we heard today? Mercer, anything that was confusing or you need more clarification on?
No, I think Mercer's all clear.
Yeah, I think we're all clear on that, and I think we're good. The only thing I would ask is of Rose. Rose, do we have any oral testimony, public testimony?
Not that I know of.
Okay.
And we will weave public comment into our conversation at the board. I assume, Bill, you and I, as the SEOW members, I read all the public comment. There were 3 or 4 individuals talking about the barriers to address their medical concerns by having the exclusion for this for GLP-1s, and we ended up getting the note from the OMA and saying that it was an appropriate addition. And then there are the 3 legislators,
3 representatives
who ended up saying that OEB and PEB should look at eliminating the exclusion. Again, they raised the point saying that this doesn't necessarily change anything, and I think that's one of the technical areas that we need to address. We'll do that. Ali, I don't know whether or not in this setting that is something that you as the director get back to them and with a comment, with that we discussed it and that we did have one question. I don't know how to to make sure that they understand that we paid attention to their.
Yeah, generally we just thank folks for the public comment, and but in this case, it's specific to the exclusion. So, I mean, that might be something I can just do once we have clarification. Yeah.
Yeah. Okay. Great. I think that would be. I think that would be helpful.
Yeah.
I'm fully expecting, and I'm not quite sure what they call themselves, but the collaboration work group that is the associations that get together and talk about OWEB. It's going to have input. It's going to have input here, and I kind of know. I pretty much know what that input's going to be as well. So
great.
Okay. All right.
Anything else?
Nice work, Bill.
No problem.
Good job.
I just
nice work.
Roll the meeting. The 20 extra minutes for lunch. What more could anybody want?
It gives me a chance to go walk my dog.
All right. We didn't have any public comment for today. I think that's what you said, Rose, or is that? I know for this afternoon, Tom asked you, but there's no public comment for today, right? Okay. And thanks everybody. See you all at 1 o'clock.
Thank you.
Well,
Thanks,
there was public comment, but we included it in.
We included it. I meant a live public comment. Sorry.
No.
Live public comment. Right. Okay. Got it. All right. Thanks everybody.
All righty.
Bye.